Maintaining the patent airway and ventilation is your main goal. If this is not done, despite of all the efforts, then they are likely going to end up with chronic thyroidotomy, also ET or endotracheal intubation. Sometimes they can do nasal tracheal or oral tracheal, depending on if the obstruction is actually in what area. So whatever they can access, they use. And if nothing else, then they do a tracheotomy. Neck trauma, which can be caused by knife, gunshot, traumatic accident, all of those things. Of course, with the neck, it's still a part of the upper airway. Priority is to maintain patent airway, so assess for any injuries, including cardiovascular, respiratory, intestinal, and neurologic damage. But in this area, in this part, again, because this is a respiratory unit, the neck, of course, if there's an injury, same idea. We look at involvement of the trachea and all that. Also assess for any carotid artery damage or esophagus. Other than just that, of course, if those are damaged, it goes deeper, then you'd see some tracheal involvement. Assess for any cervical spine injuries and prevent excess neck movement, of course. So you want to make sure that you're protecting the neck. Obstruction can occur from initial injury because of the swelling, and as a result, because of those soft tissue becomes swollen. They get enlarged and the airway passages gets narrowed, and that's when the problem starts. So other things, that some unusual things, but you'd see this, head and neck cancer. Usually they are made of squamous cell carcinoma, and it's very slow growing. It begins with mucus that is chronically irritated, becoming tougher and thicker, and as a result, there's some changes in their makeup. Usually, leukoplakia and erythroplakia lesions as a result of that. As listed, you have physical assessments and clinical manifestation. You'd see a lot of the lumps in the mouth, throat, neck. They often have difficulty swallowing with this because it's the location of it. There's some coloration changes in the mouth or the tongue. You see some lesions or sores that does not heal in 2 weeks, and they're persistent unilateral ear pain. So it's what you call a referred pain. That's why you'd see that. In addition to those mentioned earlier, there's also persistent unexplained oral bleeding, numbness of the mouth, lips, or face when there is an involvement in neuro, change in fit of the dentures if the patient is wearing those, burning sensation when they are drinking citrus or hot liquids because of the sores. One of the big one is hoarseness or change in voice quality. So that's one of the things that actually brings them to the doctor, is because they have this persistent hoarseness. Sometimes also persistent cough, recurrent sore throat, shortness of breath, anorexia, and weight loss. Big thing with anorexia and weight loss, because they can't breathe, they don't they'd rather breathe than eat, in other words. So you'd see the weight loss. Also, if there's a tumor, of course, the tumor is probably getting all the nutrients. That's why the tumor is growing. Instead of them getting the nutrients, the tumor is getting it. So you'd see that a lot with the cancer, tumorous cancers and stuff. Treatments for cancer and some interventions. They do radiation therapy, chemotherapy, or they do some surgical intervention like cordectomy and laryngectomy. This is a cartoon depiction of a throat after laryngectomy. So as you can see, they create a stoma. This is the normal, and then when they cut, this is what's gonna come out, and this is what actually where the stoma is gonna be created. Post-operative care for laryngectomy. Some of the things that you would see on page 596 talks about. There's a chart that provides information about care after laryngectomy. So first priority, of course, is the airway maintenance and ventilation. You assess their respiratory status. You observe the rate and depth of their respiration. You listen to their lung sounds, check patency of the airway, and make sure you examine the tracheostomy drainage for the amount, the color, and the character. So you check for any hemorrhage or anything like that. Examine the nail beds and mucous membranes that kind of tell you if they are getting enough oxygen. And then of course you make sure you do check their pulse ox reading and making sure that it is where it's supposed to be. You look at the condition of the wound. You by looking at the dressing, noting any conditions of drainage again. Make sure there is some wound care that's happening with this, and compared with the previous notation of wound condition, checking to see the presence and amount of any exudate or any abscess or any odor that you could see. Okay, as far as pain management, patients in this post-operatively would be very uncomfortable, so very important to keep up with their pain control. As far as nutrition, there is going to be some change in muscle mass when especially when they're not going to be able to eat as well. There will be some impairment in oral intake, difficulty swallowing, and some generalized edema during this time. Actually, it's not uncommon for this type of patient to get a TPN. As far as the speech and language rehab, after all, their voice box is affected. Therefore, they will need some equipments or different appliance to help them talk. Here are some of the tools that they can use for communication after laryngectomy. There's different brands that you would see. And then, of course, if they decided, after they healed, they end up putting like some kind of button that helps plug. So if they want to eat, they can eat. Okay. In this particular slide, it just shows there is a electrolarynx that's available. They're using that as a way of communication. As far as home care management, on page 597 talks about home laryngectomy care. It just tells you that avoid swimming and use care when showering or shaving. You don't want to wet that. Lean slightly forward and cover the stoma when coughing or sneezing, because secretion can come out of it. It's not uncommon for them to wear like a guard or loose clothing that cover the stoma. So when they're out and about, it's not all coming out like that. They need to know how to clean the stoma with, of course, we just tell them to clean it with mild soap and water. Lubricate the opening with non-oil based ointment as needed, and normally the docs will give you something for that. Increase humidity by using saline and